Hello everyone. We are going to start today our webinar about herbals and dietary supplements, and we are going to start with the definition of what is dietary supplements. First of all, what I want to tell you is many Americans love dietary supplements in general. We use these in different ways to fight colds or boost memory and or enhance muscular activity. And you know, these herbs, dietary supplements, we are going to call dietary supplements, uh, are having a very rapid growth industry. We have about 80% of the sales are being, we have increase of 80% of sales in about the last decade. So we have 50%, half of the Americans taking multivitamins. Meantime, we have herbal supplements, one every five people are going to take some herb supplements. Okay, so we spend about, they're spending just to finalize this, about 21 billion of this every year, that is in 2015. And that is actually what they spend approximately about to treat addictions. So it's kind of the opposite, right? But definitely that is what is the facts at this moment in about herbal and dietary supplements. So let's start starting a definition, having the definition of what is dietary supplements. Dietary supplements are minerals, vitamins, amino acids, and herbs. So that is what is dietary supplements. And I want to tell you this very straight, that dietary supplements, all natural is not synonymous of better. And what I'm trying to tell you here is that all these dietary supplements are not looking to treat the cause of the disease. It's mostly what they are doing is to treat the signs and symptoms, but they are not going to treat the cause itself. So that is what you need to keep in mind first. Second, we have that many people misunderstand or mistakenly think natural products are always safe, but it's not, because there is a lot of interactions that can happen, and that's what we are going to see. So this class is about 1 hour, and we are not going to be able to see the whole panoramic view of that, but we are going to talk about the most common herbs and supplements we are going to find in the market. Okay, so as a conclusion of this slide, you need to remember that we need to be careful to make during the assessment of the medications of when the patient is coming. We need to assess the type of medications that their patient is taking. And just remember, supplements can be, patients mostly, they are not going to disclose. They are taking medications, these herbs. Why? Because they don't consider these as a medication. All right, so here we have, in 1994, was when the DSHEA was appearing in order to classify the herbs and dietary supplements. Okay. All right. So one thing here that we need to remember is that all the boxes, all the containers that they have in these herbs and supplements, they are not evaluated or approved or full approved by the FDA, the Food Drug Administration. So saying that these Food Drug Administration are considered these as safe medication, but they are not completely approved by them and by the USP. The USP is the United States Pharmacopoeia. Okay, and all these labelings should be always below. They need to show in the box or in the container. Okay, so this, as you can tell, the difference between these dietary supplements and the rest of the medications are being because they don't pass through a trial of investigation, and they don't pass the trial of experimenting in animals and humans, and they don't have the phases that we have, for example, in trials in humans, phase 1, 2, 3, and 4. So they don't have that. So, and that is why we need to, they need to put in the label that they're not approved by FDA. Okay. All right, so they can see that herbal remedies do not prove safety ratings for pregnant women. So this is something that we need to make very clear women. So you need to be super careful or always ask the provider if the patient can take this and that supplements. Okay, because they can produce some problems, interactions. They can produce some problems in the fetus or in the embryo. Depends on the time, so it's variable. So actually, always need to consult your physician. Okay. Another thing that we need to remark is that most of the patients or the people who have some problem, the first thing that they go is to go to the store and buy some OTC, some over-the-counter medication to make them feel better, right? But this can produce a problem that can delay actually the time for the treatment and diagnosis of the patient. So this is something that we need to keep in consideration. Remember that these supplements are not being approved by the FDA and the USP. So example of this, we have the ginkgo biloba. And the ginkgo biloba is going to be some, this is the labeling. This statement has not been evaluated by the FDA or Food and Drug Administration. Okay? All right. So the roles of the healthcare provider being factors to consider about the supplement. You need to remember that they're scientifically tested and cannot cure serious conditions. So that is actually what I want to go in this slide, cannot cure serious conditions. So be careful with that. People who want to feel better probably going to help to relieve the signs and symptoms, but they don't have. For example, I'll give you an example. You have gastritis. Everybody has gastritis once in a while. 1 or 2 days is fine, and then you go to OTC and take some medications and you feel better and disappear. And come back probably once a year or something like that. But if this is going to continue, for example, 2 weeks straight, so you have gastritis today, tomorrow feel better, start to have gastritis again in 2 days, and so on in 2 weeks, you must see the doctor. So you cannot wait 2 weeks. You need, you wait, if you have 2 weeks already with a problem, you must go to the physician. Okay, so why? Because it could be another problem, could be a different situation. It could be a Helicobacter pylori, it could be a gastric ulcer, it could be according to the age, pain is different in adults than in elderly people, so the clinical presentation is variable. And there is no disease, but patients, different type of patients. So definitely 2 weeks is the cutoff for any OTC that you are taking. You must consult your doctor. So don't delay the diagnosis and the treatment. Okay, the assessment, when you are going to do the assessment of the patients, you will see that we have about 40 to 7% of the patients are going to fail to disclose this information. Why? As I mentioned before, they don't consider this as a medication. So that's why you need to assess very careful. How to assess it? You need to go ask 1, 2, even 3 times in different moments during the assessment, and you will see that the patient probably is going to understand that it's important, or they need to understand that it's important to disclose all this information. Okay. All right, so let's keep going. So we have the first herb that we are going to talk is the St. John's wort. As you know, all of these plants are not tested by approved by the FDA. So mostly what we are going to just is mention and what are the interactions that they are going to happen. St. John's wort. Who are taking St. John's wort? They're going to treat mild depression. So people who feel depressed, down, they are going to go to the store and buy St. John's wort. But in addition, in addition, there's a proposed mechanism of action, and this is not the purpose of this class, but St. John's wort, if the patient is taking antidepressants, the SSRI, the selective serotonin reuptake intake. So that means that you have more serotonin levels in your system. If you, in addition, take St. John's wort, the effect is going to increase. What is the problem with this is that you can reach toxic levels, because in this case they are increasing the levels of some neurotransmitter, that is a serotonin. Okay, so we have the St. John's wort is going to decrease the effectivity of the warfarin, So the purpose of the warfarin, for example, you have somebody who have a stroke, arrhythmias, and you want to prevent some stroke because of formation of clots. They are going to interact with this medication. So please, St. John's wort, if somebody have cardiac problems, arrhythmias, or previous stroke, they are taking warfarin all the time. So St. wort is something that you need to always address. Okay. Ginseng is mostly used for resistance to stress and disease. Again, ginseng is going to decrease the effect of warfarin. So mostly of you can see of the herbs so far, in the next slides, are going to have this effect on the warfarin. So they are going to have interaction. I will not say increase or decrease this time. This is what they are doing, decrease the effect of warfarin, but there is other herbs that can increase the effect of warfarin. So in general, what we need to be careful is just to, if the patient is taking warfarin, always look for supplements. Which supplements are taking the patient in order to stop them. Milk whistle is people who suffer from liver problems, is protecting the liver somehow to regenerate. That is what they use, especially people who are on alcoholism or liver disease. What they are doing, the milk whistle twistle, is the decrease the metabolism of the benzodiazepines. What are the benzodiazepines? They are going to be used as anti-anxiety. So they are going to calm down the patient, and that is what is, if the patient is having this treatment, if you're taking additional milk twistle, they are going to decrease the metabolism of the benzodiazepines. What happened? The decreasing the metabolism of benzodiazepines is going to increase the concentration of the benzos. So it can reach toxic levels. Black cohosh is used for PMS, dysmenorrhea, menopause. One is the interaction of this black cohosh is when the patient is taking antihypertensive. If you take antihypertensive, there is going to increase the effect of the antihypertensive medication. So you will have hypotension, okay, orthostatic hypotension. Echinacea is being is immunostimulant. People take it because they have a cold, they have some infection, and they want to increase the immune defenses. So, but there is something that we keep in consideration here, that is autoimmune diseases. Patient who has lupus, psoriasis, or some another kind of multiple sclerosis or something additionally, autoimmune disease. Autoimmune disease is that the immune system is going to destroy some part of the body, right? Kidney or skin, whatever. And if you give echinacea, you are stimulating that activity. So actually, it's not. You need to consider that echinacea should be removed on the list of the patients who. So in other words, not to take the echinacea. So palmetto is used for BPH, benign prostatic hyperplasia or hypertrophy. Again, we are not going to use with anticoagulants because they're always there. In this case, is going to increase the risk for bleeding. Ginkgo biloba is used for short-term memory, and again, anticoagulants can increase the risk for bleeding. So I'm trying to focus in something that is more often, that is about the interactions of warfarin, especially with anticoagulants. I have a list at the end that is going to make a summary, that is going to be all the information together. All right, so here garlic, when a patient is taking big amounts of garlic, So all the time, if you like garlic and take big amounts all the time of garlic, they can interfere with some hypoglycemic drugs, especially patients who have diabetes. So just be careful with this. In addition to that, reduce the platelet aggregation, but garlic need to be taken in big amounts, but definitely is part of your assessment. Aloe vera is different presentations. They can be, mostly they are being used for skin irritation, minor irritations of the skin. And they, you need to be careful with diabetes mellitus because they can decrease the amount of glucose, concentration of glucose in blood. So they can produce hypoglycemic states. Ginger is a root that alleviates the nausea and vomiting, and ginger may slow down the clotting process. So we are going to see the list of which medications are going to be affecting by warfarin or interaction with the warfarin. We have gin with few garlic. So those are the herbs that are going to interact with the warfarin. So I didn't state that some of them are increasing, some of them are going to decrease. But what I want you from this webinar is just to remember which herbs are the most commonly affecting this clotting process. We have gin, we have ginkgo biloba, we have ginger, we have ginseng, and few is the we have the feverfew, and the end garlic. All right, so those are medications that always we need to be alert when the patient is coming and you make the assessment or the history for medications. Cranberry is one of the most, probably the most, the product is most sold, is being selling more in the market. What they are doing is to eliminate the, decrease the elimination of many drugs renally excreted. In addition to that, they are going to produce acidify the urine. Acidify the urine, they can be used to for prevent urinary tract infections. Again, they will not cure from urinary tract. It will help, yes, but it's not going to cure the urinary tract infection. So, you know, the acidity of the urine is going to prevent the growth of the bacteria. So bacteria doesn't like acid. So that's why cranberry is going to help to decrease the amount but not cure if you have some UTI. Okay. Again, we have interaction with the warfarin. Chamomile is an anti-inflammatory, spasmodic, anti-spasmodic, mostly people taking after a meal to stimulate the motility of the GI tract. And again, there is no taken with warfarin. So many medications can lead into interaction with warfarin. Grapefruit is going to be used mostly as a type of diet where you are going to, they use to weight loss and promote health, cardiovascular health. And the grapefruit, what it's doing is activating some enzymes in the liver. And these enzymes can mostly, the liver, with this enzyme, what they are doing mostly is inactivation of the medication, inactivation. I would say 85% of medications are that interact with this with enzyme is going to be inactivation. So the grapefruit, take the grapefruit. This grapefruit activate enzymes in the liver. These enzymes is going to increase the process of inactivation of the medication. The other small group is going to just activate medication, but the majority are going to inactivate. So what does it mean? Inactivation, that is you're going to need more dose. The dose is not going to be effective, and actually many medications need to be metabolized by the liver. And what happens is the medication can reach toxic levels. Valerian is one of the used for restlessness, promote sleep and relaxation. Is going to produce sleep and relaxation. So if you take in some central nervous system depressors, they can actually produce a summative effect. So they are going to some effects between valerian and so avoid with other central nervous depressants. Feverfew is used mostly for treat migraines, and what they are going to do is slow the blood clotting. Green tea improve cognitive performance. They is used as a diuretic. They can increase the decrease the cholesterol, decrease the LDL, and increase the HDL. All right, so we are going to see the summary of these main herbs, and here we have the list. So if you see here, herb name, common use, interactions, and cautions with patients. So if you see on the right column here, you will see that all these are the most common. All the most common, there are 10 or 11 of them. And you here we have anticoagulant, 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 anticoagulant. We have other ones, that is hypertension, diabetes mellitus, and depression. So what a conclusion I would like to have from these slides is that mostly of the herbs can produce problems in the cardiovascular system and the endocrine system and the nervous system. So nervous system, any patient with nervous system diseases, any patient with metabolism disorders like diabetes mellitus, any with cardiovascular problems, those are the ones that we need to address more accurately in order to investigate what kind of herbs are taking the patient. Okay, so let's talk about the substance abuse. That is the second part of the webinar. So we are going to first of all define, make definitions of some basic things that is going to help you to understand what is the role of the nurse in these substance abuse patients. So first of all, we need to talk about illicit drugs. Illicit drugs is prohibited drugs, in conclusion, right? So mostly they're going to use for entertainment, whatever you want to say that, psychedelic drugs that are going to be illicit drugs. So they are not being sold, they are not being prescribed, so those are prohibited drugs. So when a person is trying to take, but not all are going to be, I would say, for example, alcohol. Alcohol is not prohibited, yes, but patients can start having some abuse of that substance. So substance abuse is a periodical, purposeful use of the substance that leads to clinical significant impairment. So you start to abuse alcohol, you start to get into another area that is dependence or addiction. Okay, as you know, alcohol can be addictive. There's other drugs that can be much more addictive than alcohol, and that's what we are going to see in the next slides. So just to see the trend of how are the substance abuse in the United States. From 2000 to 2013, we have from 5 almost after 12, 13 years, it's been duplicated the number of people who are using this or having substance abuse. In 2017, approximately, I guess, is going to be about 10%. So that is the trend. So don't confuse intoxication with withdrawal. And I'm going to give you a tip how to assess how to recognize the patient who's having these problems. So don't confuse intoxication and withdrawal. Intoxication is the excess of the drug. Withdrawal is when you try to stop the medication and you have already this physical and psychological dependence. All right, so we have focused on vital signs of pupils. So vital signs are going to be variable. They're going to increase in some, they are going to decrease in others, and pupils is actually the way that they can be recognized very fast, as we are going to see in the next slides. All right, so theories, biological model. So we have predisposition. We have these patients who is having substance abuse are coming from, for example, dysfunctional families. They have some predisposition. For example, you know, alcohol is running in family, right? This is a very common expression. And we have, there is some problems in where psychological situations where they are going to stop some stage of the development during childhood. So for example, oral stage. This is not the purpose of this class to talk about oral stage, but definitely when the baby is trying to recognize the outer environment with the mouth. So they put objects and they try to feel the taste, the shape, the texture with the mouth. So when they cut this face, because the mother said, okay, you cannot put this in, or I don't want you to put this in your mouth because it's going to be bacteria or something, that what you're doing is just to cut in that development. So the process where the baby starts to recognize external scenes. In adulthood, that is going to be translated in some few scenes. For example, alcohol. It could be translated into smoking. Okay, so here we have smoking. When somebody is trying to stop smoking, you have these cravings that is going to last for about 6 months. So that is the highest, or more intense for cravings in the first 6 months. Chewing a gum and versus a patch. So what is faster? So the patient is going to feel some relief faster with chewing a gum. It's going to be released faster than a patch. Okay. All right. So which psychological traits are linked to substance abuse? Dependent personality, depression, and anxiety. What is depression? Dependent personality. Those patients who need always reinforcement. They need somebody. They cannot make decisions, even simple decisions. They cannot make it by themselves. So they always try to rely or depend on somebody else. Depression is isolation, no social activity. They are not communicating with other people around them. You can check this with patients with depression, how they are dressing, how if they are dirty or clean. They don't take care of them at all. They have actually, the appearance can tell you if the patient is suffering from depression. And anxiety. Anxiety is the fear for something that you don't know how to resolve. So that is, all these three components can be making you a clue of this patient is having some substance abuse. All right, so when the patient is being sent to have an urinalysis, the urinalysis is going to show the presence or not of some substance. But they are not going to tell you how long I've been taking the drug, how much is taking the drug. So only just the presence is positive or yes or negative. Okay, so substance abuse, we are going to talk about different substances. We are going to talk in this class about cocaine, amphetamine, alcohol, opioids, sedative, and hypnotics. Hallucinogens are going to be touched in another moment. We will talk about a little bit about nicotine and caffeine. All right, so I put it here in this, what is in common between these groups? Cocaine, stimulant, amphetamine, stimulant, alcohol, depressor, opioids, depressor, sedative, depressor, hypnotics, depressor. What is sedative? Sedative are for example, benzodiazepines. Those are considered sedative, and you can have toxic levels. You can be dependent. You can be having some addiction to the benzodiazepines. So benzodiazepines is calm you down. So that is being used mostly for treat anxiety. Hypnotics is going to be used for people who, for example, have problems with sleep disorders. Hypnotics is going to promote the sleep. Okay, so there is a difference between sedative and hypnotics. All right, so what is the long-term care goal for the treatment? First of all, to reduce the signs and symptoms of the abstinence and the recurrence. So they are going to reduce the frequency and severity of the relapse. So they are going to take another time and again the drug after they stop. So why? Because we have involving the psychological and the physical dependence. And for this, we are going to use some medications that are going to, number one, decrease the anxiety of the patients, the physical signs and symptoms like tremors, like nausea, like vomiting. So those are going to be talked in the next slide. So as we mentioned before, substance abuse, we will divide it in three main groups. We are going to talk about two groups today. stimulants and depressors. The stimulants will be the cocaine and the methamphetamine, and depressors are alcohol, opioids, and benzos. Okay, so talking about the stimulants, the cocaine is one, and the methamphetamine. So please just remember that we have another word that is called amphetamine. Amphetamine, and the other one is the methamphetamine. What is the difference between them? Amphetamine can be used for some attention disorders, okay? That is amphetamine, but the methamphetamine is not used for that, even though that there are similar chemicals, similar functions, properties, but we don't, methamphetamine is prohibited because it's very highly produce addiction. The amphetamine have addiction too, but not as much as the methamphetamine. All right, so let's talk about that. And I was telling you that we need to focus in vital signs and the what, and pupils, right? So in the stimulants, we have cocaine, methamphetamine. The vital signs are going up. So vital signs going up. So that means heart rate go up, the respiratory rate, heart rate, high blood pressure. Okay. So and these are going to be for cocaine and methamphetamine. And what are the pupils? The pupils are going to be in mydriasis. Okay. So for NCLEX, they are going to ask you what are some main signs and symptoms of these stimulants. So what we have here is the effect. So that is high levels of, I mean, the effect itself of the drug. So we have diaphoresis, we have very talkative, and euphoria. They are going to have euphoria. All right, so one thing we need to remember is to check the nasal septum perforation. The cocaine mostly is the one who is being inhaled, and this cocaine is anesthetic too. So produce numbness on the area and produce vasoconstriction. Vasoconstriction means that there's less blood flow to the area. It's going to produce ischemia and then necrosis. So what we have is a perforation of the nasal septum, and this is something that we need to address. So now, when a person is having overdose or intoxicated, so you start to have this hyperthermia, psychosis, arrhythmias. So everything is going to be augmented more than just to increase the vital signs. So you can end into seizures. Mostly these intoxication levels of any drugs can lead into seizures, coma, and death. Okay, so what is the treatment for these stimulants? Is the Benzos. Benzos is going to just calm the anxiety of the patients when they are actually trying to get more of this substance. Antipsychotics, and we have all antihypertensive medication. So basically what we are doing is just to treat the signs and symptoms. All right, so opioids withdrawal syndromes, opioids and cocaine, so they are similar on that. We have that the opioids and cocaine withdrawal syndrome is going to be mood swings, slurred speech, okay? And what we need to consider here is, in addition to the sweating, the nausea, the vomiting, and some fever sometimes. Also, hyperthermia is commonly seen here when you have the withdrawal syndromes of cocaine, opium. The nursing diagnosis will be the high risk for self-directed violence. So the patient become very agitated, very active, and with this we need to just make all the nursing considerations about the high risk for self-directed violence. Clonidine is alpha-2 that is used too for tremors and agitation, so it's going to be used for as one of the medications for withdrawal syndromes. All right, so let's go full of the treatment of this group. We're talking about the stimulants, cocaine and opioids. Cocaine, sorry, and methamphetamine. Okay, so here we have the naltrexone. is an opioid antagonist. It's used for in this case. And what it's going to do is to eliminate the euphoria that occurs with opioid drugs. All right. So naltrexone, we have the amphetamine. Amphetamine is used for attention deficit disorders, but that is prescribed by the doctor, but we don't do the methamphetamine. All right, intoxication about these drugs is going to produce sense of highness, alertness, attentiveness, self-confidence, powerfulness, and energy, and frequently leads in additional dose and may stay awake for 7 to 10 days. Okay. All right, so just remember the met mouth. Met mouth is patients that's actually methamphetamine mouth. They have a poor oral hygiene. Amphetamine, for methamphetamine, there is no antidotes. Unfortunately, there is no antidotes for that. What we are going to do is to treat after the patient is being, we are treating just the signs and symptoms and trying to keep him away from the substance. So psychiatric evaluation is needed in this case. And we have all different kind of support groups, for example, that are going to help for the treatment of this group of patients. We have the depressors. The depressor, we are going to talk about alcohol, opioids, and benzos. So depressants is going to be what we just mentioned, and again, your pupils and your vital signs. Your vital signs are going to go down, and the pupil is going to be meiotic. Meiotic means very narrow opening of the pupil. Okay, so we have here, for example, they can produce breathing depression, respiratory depression. So they can lead into respiratory arrest. So what it should be giving is a ventilatory support to consider is the patient having alcohol, opioids, or benzos intoxication. For benzodiazepines intoxication, we mostly, and please remember, open eyes, open ears here, is the flumazenil. Flumazenil, that is the benzo antagonist, And the naloxone is going to be the opioid antagonist, naloxone. Okay, so alcohol is the same to say ethanol, or the ethyl is ETOH. The withdrawal syndromes start with shaking, with nervous sweating. You start to have increase of your heart rate. You start to be shaking, more shaking, and then you start to have hallucinations. Hallucinations can be visual or auditory hallucinations. Most commonly, it's happening in the visual hallucinations. What they see are, for example, insects or cockroach running over the body, his body or her body, and that makes him more agitated. In addition to that, they are going to start having some shaking and seizures and loss of consciousness. Okay. All right. So some of them signs and symptoms may continue about for 3 to 10 days. They can start after a few hours or 1 or 2 days. Think about the fetus who the mother is taking alcohol. The fetus is born, is no more source of alcohol. Fetus or the neonates are going to start having physical dependence. So start to have seizures in about 2 or 3 days after the delivery. Treatment of alcohol is going to be thiamine. Thiamine is the B1. That is going to prevent the Wernicke encephalopathy. Wernicke encephalopathy is a type of dementia. We call Wernicke encephalopathy is Wernicke-Korsakoff psychosis dementia. Wernicke-Korsakoff, we call Wernicke-Korsakoff when it's more advanced, when it's more severe, the cognitive level of the patient. Benzo treatment, we have benzodiazepines for alcohol, for opioid, because they are going to decrease the anxiety for taking more medication. Anticonvulsants, if the patient is having convulsions, we are going to prescribe that, or they are going to be taking that. Beta blockers is used for tremors. Disulfiram is to maintain the sobriety. So disulfiram is after the patient is having the process of detoxification. They don't have more alcohol in blood. And disulfiram is going to keep the patient in the without taking alcohol. Because if they take alcohol with disulfiram, they are going to start having nauseous, vomiting, very, very, very strong, very severe nauseous and vomiting. So that's why we wait until the patient doesn't have alcohol in blood, because if they're still having some alcohol in blood, if you give the disulfiram, it's going to react against that. Naltrexone is being used for this reason too. Naltrexone, is going to be used for, they are going to increase for the reason of alcohol and opioids, because they increase the GABA receptors, and these decrease the need of craving for these drugs. Acomprosate is not known very well the mechanism of action, but they are going to keep the sobriety of the patient, and they can be used, depends the protocol, they are going to make some combination of disulfiram, naltrexone, or acomprosate. Clonidine is used for tremors. All right, so let's talk about disulfiram, the anti-abuse effect. Disulfiram anti-abuse effect. Please open eyes, open ears here. So we have the disulfiram produced in interaction with the alcohol, nauseous, vomiting, pulsating headache, okay, pulsating headache, and difficult breathing. All right, so this is not used for acute intoxicated patient. You cannot do that. Why? The patient cannot receive that. Why? Because it's still alcohol in blood. If you give the disulfiram, it's going to produce this severe side effect, nausea, vomiting, and difficult breathing. Patient, actually, you need to, during your assessment and your interventions, you need to be sure that the patient is not surrounded by alcoholic beverage. For example, mouthwash, or for example, perfumes. Any substance that can have some alcohol can be ingested by these patients. All right, so prevention of alcohol relapse, we have the naltrexone, as we mentioned, is going to block the opioid receptors, okay, and is going to increase the GABA receptors, decreasing the craving, the need for more alcohol. Okay, so what they are doing to do is to decrease the number of relapses. Acomprosate is going to promote the abstinence, so the sobriety of the patient, using alcohol in rehabilitation programs. The common side effect of this acomprosate is going to be diarrhea. All right, so what happened is somebody in your job area is having some problem with alcohol. A coworker suspects that a colleague is abusing alcohol. The state guidelines may mandate to report substance abuse. So you need to report it. How? Document a specific example of inappropriate actions and submit a confidential report to an appropriate supervisor. Okay, patient education should be included about disulfiram. The patient should return for liver functions every 2 weeks, 10 to 14 days. So every 2 weeks, following the initiation of the therapy. You need to tell the patient that there is very common to have headache, fatigue, and metallic taste that are common side effects that can be resolved in a few days, about a week or 10 days. So they are going to go away. So avoid alcohol ingestion to prevent a reaction. So if the patient is going to start taking alcohol, meantime is taking disulfiram or anti-abuse, they are going to start having very hard problems with nausea and vomiting. Carefully with all the levels of possible alcohol. So as you remember, all the products that have some alcohol in, they can be putting away from the patient. Opioid withdrawal, we are going to use methadone. We can use and or clonidine, catapress. What is methadone? Methadone is an opioid. But this methadone is having less addictive properties from the rest of the opioids. So that's why is at the beginning they are going to start giving methadone. Benzodiazepines is these drugs are being used for actually some aggressions like facilitate sexual assault, and we have different benzodiazepines being used for this reason. Is the flunitrazepam, midazolam, temazepam. The most common and the most wider spread is the flunitrazepam. So those are called the so those are recreational drugs, considered recreational drugs, called roofies. That is what they call the date rape drug. All right, so roofies is because ruiphenol is the name of the medication, so that's why it's called roofies. Okay. All right, so hallucinogens we are going to talk another time. Let's talk about the smoking withdrawal. The smoker withdrawal can start as soon as half an hour after you stop smoking. Signs and symptoms of this withdrawal is headache, increased appetite, dizziness, constipation, stomach pain, fatigue, and insomnia. So that is the withdrawal signs and symptoms. All right, so just remember that this craving for smoking can last for even months, 6 months. So it's not that easy to stop smoking. So for this, there are some medications like nicotine, like varenicline. So open eyes, open ears, varenicline, the bupropion, right? And nicotine is, we can have an inhaler, transdermal, gum. There is different ways presentations. What can cause this is cough, insomnia, and irritability. The other medication that is being used is the Chantix or Cantix, is the varenicline, that is a nicotine receptor agonist. So that is going to decrease the craving of cigarettes. Side effects, drowsiness. More severe effects are agitation, depression, and suicidal thoughts. Suicidal thoughts, important. Bupropion is an antidepressant, and this is used for depressive presentation in the patient. Okay. Pregnant woman, the only thing I want to say here is when you're talking about herbal and dietary supplements, or when you're talking substance abuse, any of these substances are going to be need to be used during pregnancy. It's variable. If you take it, for example, these medications at the beginning of the pregnancy, you have a risk to have some fetal malformations. If you have these drugs on the middle of the last period of the pregnancy, the patient is going to have low weight at birth. They're going to have some IQ problems, right? So the intellectual level is going to be lower, and they have some physical or characteristics that we are going to see, for example, in FAS, the fetal alcohol syndrome. So at any moment of the pregnancy, you need to be extra careful with the herbs and dietary supplements and avoid any toxic substance that can produce some dependence. Breastfeeding, the one thing we need to remember that medications can pass through the milk, especially the benzodiazepines. The benzodiazepines can lead into dependence in the mother and in the baby. So benzodiazepines, if you take it normally like 1 or 2 weeks, you need to taper the medication. Otherwise, you're going to get into a withdrawal syndrome. All right, with that, we finish the webinar today, and I want to thank you everybody for to attend, and I will see you next time. Thank you.